لا
ايه نوع اللجنه الموجوده هنا في يعني كل اوت بيشنت. هو انتوا مش محتاجين حاجه مثلا زي الناس اللي تدخل هنا في البيشنت لسه؟
اكيد طبعا اكيد.
طب هو موجود على فكره يبقى ايه يا دكتور يعني؟
يبقى ايه بس دخل هنا ولا الصيدليه ما جابتوش؟ وده السؤال.
كلمت دكتور هنا ان شاء الله هحاول اتكلم معاه.
يعني موجود يو بي اس ده كلام واسع. لكن انا بتكلم هو موجود في الصيدليه، عشان انت لو كتبته هنا في الصيدليه مش هتلاقيه.
طب هو حتى حاله هتحتاج ريكومنديشن من حضرتك.
سهل.
بس خلاص
سهل.
يبقى كده سهل ان شاء الله كده خلاص، عشان البيشنت برضه يستفاد منه. هو على فكره
دكتور إبراهيم، اليوتيوب بدأ بقاله شوية.
شكرا يا دكتوره زهره.
تمام.
شكرا جزيلا. دكتوره ريتا، يعني we are enjoying that you are adding a very benefit presentation to our weekly seminar in Aswan General Hospital, General Surgery Department in Aswan University Hospital, Faculty of Medicine in Aswan, and this is the seminar number 93 weekly, 93 weekly, and we are have a lot of information, a lot across the last weeks. We are talking about breast from different views, and we are continuing the breast now with you for escalation, breast surgery during escalation period. Yeah, if you need to start, you can start now.
Sure. Good evening, everyone. And this is my great pleasure to share the summary vision about the era of de-escalation of breast surgery. We know that, can you hear me? Is it clear? Is my voice clear?
Yes, we are hearing you very well. Yes.
Okay. So I will be separating the de-escalation of breast surgery into three parts, summarizing a little bit the era from before and now from the latest updates where we are going in the future. So de-escalation in breast surgery, it means using less extensive surgery. So when it is safe and when it is effective. Definitely, we need to highlight and to focus on the quality of life of the patients, on reducing the level of complications, and the point is to avoid unnecessary procedures, mainly based on the advances in all the systemic therapies that we are using now in breast cancer treatment. So we know from before historically that we had the impression that larger, extensive surgeries means safer. So this was the impression we had from before, and this was made like routinely process that the more extensive means safer for the patient, which over time is shifting towards not necessarily larger means extensive, means safer, but better understanding the tumor biology is safer. So the surgery is now more individualized in the management of treatment of breast cancer. So the key areas is the breast surgery, the lymph node surgery, and the breast surgery is in itself between conservative and total mastectomy, how the de-escalation happened, and what is the effect of the medical treatments on the use of breast surgery itself. So breast conserving surgery usually means removing of the tumor, conserving the breast. So often it's definitely combined with radiotherapy, and the studies have shown that when we consider the survival outcomes, it is similar if we compare breast conservative surgery and radiotherapy to total mastectomy that we were using before historically for breast cancer treatment. Now, considering lymph node surgery, we know that earlier approach from before, again, it was removal of as much lymph node as possible. So we had moved from complete axillary clearance to less, which with sentinel lymph node biopsy, and now the future is also considering when to omit sentinel lymph node biopsy in the axillary management. So we are de-escalating as well in the lymph node approach. And the role of the treatment is very crucial in this de-escalation era. Now, with the advances with systemic therapy, targeted therapy, hormone therapy, allowing the shrinkage of the tumor or allowing us to omit most extensive surgeries. So those roles are very well considered, and this is the multidisciplinary approach that is playing a huge role, as well as the patient selection. So again, it is very personalized, as every treatment, de-escalation is not one size fits all. Like any kind of treatment, any kind of surgery, there are many factors that we should consider: the tumor size, the response to treatment, the patient preference. Also, we need to discuss and we need to tailor every treatment to every patient, which makes the decision making shared definitely with the patient. I'm so sorry about my voice. I had a severe flu since few days. I'll try to go very slowly. Now,
We are so sorry for you.
now the benefits are definitely comparable for the cancer control when we really are careful with the selection of the patients. Selection of the patients is crucial in the decision making, reducing the surgical complication, focusing on the quality of life of the patient with this more personalized care. So, in this first part, let us first start with the de-escalation from mastectomy to breast conserving surgery. As you know, like when we started treatment of breast cancer many years back, the mastectomy was the standard treatment in most of the cares until breast conservative surgery with radiotherapy had shown the equal benefit in the survival and the outcome. So this was historically the first de-escalation that was seen in the history after understanding the mastectomy and the breast conserving surgery. So we need to explain and to understand and to review how and why the de-escalation is possible, and discuss always discussing with the patient the selection and the outcome of each treatment. So instead of mastectomy, where we remove the entire breast, the breast conservative surgery allows removal only of the tumor, preserving the breast tissue. Of course, every time conserving the breast, we need to consider the radiotherapy in our decision, in our planned decision making. So aiming this was to maximize the local controlling of the local disease and with a better physical impact. We have also to consider that the body image and the emotional effect on the patient are very crucial in the decision making of the treatment. And if we go back historically and we go back to all the studies, more does not mean better. Considering a total mastectomy or any kind of mastectomy doesn't mean a better survivor. So we really should shift the era of the treatment and de-escalation with a better explanation, better education of the patient, and highlighting that doing more and considering the mastectomy doesn't mean necessarily a better survival when we are discussing and explaining with the patient. So, reducing the surgical extent of the surgery, avoiding unnecessary removal of the tissue of the breast, based again on evidence on studies based on all the NCCN and all the guidelines concerning the breast conservative surgery safety as on the outcome as on the survival. So with those many advances in cancer treatment, we understand that breast conservative surgery allows us to better understand the tumor biology after removing the surgery, the lump, the tumor, and analyzing the biology, and at the same time allows us also to focus on the quality of life of the patient. So those were key advances in supporting the de-escalation, the systemic therapy, the advances in the systemic therapy. So again, the breast cancer is a systemic cancer, so the treatment is not only about performing the surgery, it's also about giving the appropriate systemic treatment after analyzing the proper biology of the tumor. And when we consider the conservative treatment, the effectiveness of the radiotherapy. So those were proven with long-term trials that we should really highlight to the patient when we explain the benefit of the conservative surgery as compared to what we were doing many years back with the mastectomy treatment. So many studies have supported the evidence that survival is similar when we consider conservative surgery with radiotherapy as compared to mastectomy, and those were in many were proven in all kind of biological and all kind of types, invasive, intraductal. So that we should be highlighting to the patient when we are explaining the benefit of the conservative surgery. The outcomes, the survival outcomes were also proven in many studies and all confirmed within the guidelines that we showed to the patient, confirming that the local control is effective. And with the proper follow-up, this reinforces our explanation to the patient about the safety of breast conservative surgery. We also explained to her the role of the radiotherapy after breast conserving. It is an essential component and it is allowing certainly improving the local cancer control and a huge benefit on the overall follow-up. Again, as I mentioned earlier, it is a patient-centered care, so we should analyze it case by case, depending on the size of the tumor, depending on the location of the tumor, single versus multiple tumor area, and of course, including the patient in the decision. So this is why the imaging, planning our management, our treatment with the proper use of the imaging, and now with the advances that we have with the all kind of pre-planning imaging from the mammogram to the MRI to the contrast mammogram when required. So it will definitely help us to achieve a better understanding, better planning in deciding if the patient is eligible for the conservative surgery or not, and then if we can achieve the clear margins or not. So this will help us also to, as much as possible, explain and reduce the need for a repeat of the surgery. To mention also, one of the points is the advances with the when we apply the neoadjuvant chemotherapy. So this will also give us better chances in shrinking the tumor. So we have better chances to achieve conservative surgeries as compared to immediately going to mastectomy before the era of the neoadjuvant systemic therapy, which has a huge impact on the tumor shrinkage and then definitely giving a better chance to the patient in conserving the breast. So in practice, we assess the response to the treatment. We reevaluate the surgical options after the neoadjuvant treatment to choose a least invasive effect approach psychologically and medically on the patient, affecting then the cosmetic and the psychological benefits, which is very crucial also to highlight how we can preserve the body image, the self-confidence of the patient, and reduce as much as possible the emotional distress. Definitely shorter recovery of time with the conservative surgery, less physical limitation, and faster return to daily activities in general. So in summary, it's definitely a patient-centered care when we are making the decision to de-escalate from a total mastectomy to a conservative surgery. It is evaluating in a multidisciplinary approach and then explaining and sharing the decision with the patient. So again, as we go further in every kind of decision, especially in breast cancer treatment, it is a multidisciplinary team role. So we are all together in the making of the decision between surgeons, medical oncologists, radiology, radiotherapists, the support staff. So again, it is a multidisciplinary approach to evaluate in a patient-centered way the feasibility of conservative surgery as compared to total mastectomy. And we need to consider the cultural aspect depending on which country we are, especially in our countries where it is very common to face a patient who is completely convinced that doing more is definitely safer, and then to explain to her that the conservative surgery with radiotherapy is equal in the matter of survival and the outcome. So it is definitely has to be highlighted to the patient. Now, having said all that, we still have like sometimes medical indication for mastectomy. Of course, it is the era of de-escalation, saving the body image, taking care of the like shorter recovery and better psychological outcome. But when the indication for a mastectomy is medically needed, then we need to keep it in our mind. This is why we need to keep like a good formative educational explanation with the patient. When the disease is very extensive, multicentric, when there are many tumor areas, when the location of the tumor is making it difficult to conserve any part of the breast, then we need to educate the patient and explain and share like also her preference in the management decision making after our multidisciplinary discussion. So again, as I mentioned a few slides back, like we need to address the patient concern depending in which culture, with which culture we are dealing, which country we are. Many patients will see that they come and they have like a terrifying fear from recurrence, and they will be insisting on having the mastectomy because they could not live with the fear of recurrence after breast conservative, even if we reassure them that with radiotherapy and systemic therapy, we are controlling that risk of recurrence. So sometimes we have misconceptions about more surgery is better, which like I personally encounter very regularly in our countries, and we have to really make sure and keep a huge value on the importance of educating the patient to rectify those misconceptions and help her with the decision making. To make sure that we are avoiding overtreatment, unnecessary overtreatment, in spite of course, respecting the informed patient choice, of course. Now, this is just what was summarizing. Now, with having said that, with the breast oncoplastic surgery, as you know, we are integrating the oncological safety with good aesthetic outcome. So this will allow us to better explain also and help the patient in her decision making when we are trying to advance from the total or untotal nipple sparing or other kind of mastectomy to the conservative surgery. So by educating the patient that even with a larger tumors as compared to the breast side, we can complete the tumor, we can achieve a complete tumor removal with clear margins, preserving the shape of the breast with the new technology that we are now acquiring, and we allowing us to do like larger section. But definitely the main key is educating the patient. So we have to educate her that we are highlighting first the oncological safety in our approach, trying to do our best to keep an aesthetic outcome, to keep the symmetry, and always reassuring the patient that we are deciding all together in a multidisciplinary planning. This will reassure the patient and help her to achieve the decision and stay away from the misconcept. So we have to also, in our multidisciplinary approach, highlight the level, even if we decide like we can keep the breast where our for large tumor, we have to classify it properly. We have to select properly the patient. When we can do this surgery, we have to be reasonable and select properly the patient. Be aware of the contraindication. So not trying just to be heroes, just to do the surgery. We have to analyze it properly and recognize when it is contraindicated, multicentric disease, very small breast, inflammatory carcinoma, when sometimes the tumor location make it difficult, the breast size, the patient preference. So we have to educate the patient and help her with her decision and not decide for her. Make a very good planning preoperatively. Again, multidisciplinary approach is a key. We need to correlate properly the imaging to the biology, to the cosmetic aspect of the patient in our decision. Knowing the anatomy, knowing properly the anatomy from artery, vein to nerves, we have to know very well anatomy. We have to have the very proper training when we go to the preoperative marking, performing the procedure, taking care of a very good post-operative care to make sure that we are, after our surgery, we are respecting the many rules and guidelines in our from the surgery itself to the follow-up to monitoring any kind of complication after, again, a proper education of the patient, checking for all the outcomes, oncological, aesthetic, psychological. Never ignore or undermine the psychological effect and the technical aspect, having good training for any kind of procedure we need to go ahead with. Of course, we have many limitations, many challenges for any kind of surgery, especially when we go for oncoplastic conservative surgery. So we need to have specialized training. We need to explain the operative and what are the potential risks, what are the potential multiple probably surgeries that are required, and make sure that we have access to many kind of future directions, and then again the patient education and approach and the multiple educational levels for us. Now, having said that about the from mastectomy to conservative surgery, now in the mastectomy itself, so there was an era where we had shifted from the total mastectomy to a mastectomy preserving the anatomy, while of course maintaining oncological safety for the patient. So if you are my generation, you know very well that we were, like many years back, started performing whenever it's required the total mastectomy, with the patient becoming completely flat, and then like the advising is secondary reconstruction if required. Now, having moved like further, we had the nipple sparing mastectomy and skin sparing mastectomy were introduced, and it has shown like good benefit and good outcome without the risk and the jeopardy of the aesthetic and the total mastectomy aesthetic outcome. So this breast surgery has evolved. So the approach was less extensive and less difficult on the patient. But definitely, we have to make sure that we are improving the quality of life without jeopardizing the oncological safety. So, this is where the nipple and skin sparing mastectomy had represented a new era of de-escalation strategy in the mastectomy. So instead of removal of the whole breast tissue and becoming totally flat and then considering another stage for the reconstruction, so it was possible to remove the whole breast without removing the skin or the nipple. But definitely we have to make sure that this is properly evaluated initially in order to make sure that the feasibility of this procedure is correct. So it will allow a safe preservation of the skin of the nipple. So again, never jeopardizing the oncological safety when we are evaluating. The de-escalation from total to nipple and skin sparing mastectomy will definitely avoid unnecessarily removal of the structure, preserving the aesthetic outcome and the psychological, the body image outcome of the patient. So this is a patient-centered care focus. It will improve the cosmetic appearance, better body image, and mainly psychological and emotional benefits. But again and again and again, after a pre-operative planning, a very proper pre-operative planning. With high resolution imaging, we have in our multidisciplinary approach, we always evaluate with the breast radiologist how far are the lesions from the skin and from the nipple, how multifocal or multicentric image lesions are. So it is a good with a good evaluation, we will achieve like proper planning, the tumor mapping, the surgical techniques, are they feasible or not? So this is what will allow us to have a procedure with maintaining the oncological safety. And during the study that had compared the nipple and skin sparing mastectomy, it had showed comparable cancer control in those selected patients. So if we are properly planning our procedure and properly checking the imaging in our multidisciplinary team approach, then we can definitely achieve an oncological safe procedure and preserving the aesthetic outcome of the patient. So the patient selection after the proper imaging planning is very crucial. The tumor should not involve the nipple. So this is definitely a main criteria. Adequate distance between the tumor and the nipple. And definitely we have to check how far it is from the skin in our evaluation, in our imaging pre-surgery evaluation. And of course, the patient preference. So we have to educate again, inform the patient, and help her and guide her with her decision. The role of the imaging is very crucial in our decision for a skin or nipple sparing mastectomy. It will mainly help to assess the nipple involvement, even if we can surgically try to analyze the shaving, retroareolar shaving when we are performing the surgery. The preoperative planning with the imaging is very helpful. So the surgical technique will allow us to remove the breast tissue under the skin, and with the same time, when we decide about our incision, we try as much as possible to protect the nipple supply. So this is why there should be a very proper coordination and proper planning, pre-surgical planning, to decide about the immediate reconstruction after removal of the breast and then filling this pocket that is formed by the skin and the nipple. It can be implant-based or tissue-based, definitely. I will not go through the details of the type of reconstruction after nipple or skin-sparing mastectomy, but as you all know, we have different kind of incision that we can consider. It will depend on the ptosis of the breast, on the localization of the tumor, on the aspect of the skin. So those are all pre-surgically evaluated in order to make a proper planning. The outcomes will allow us to have a more natural appearance, better symmetry, and better satisfaction rate from the patient. We have also always to explain to the patient and to educate. Again, I always highlight the educational part of the patient, because whenever we are performing a procedure where it is, in addition to the oncological safety, it is involving the aesthetic outcome, we have to prepare the patient to a potential requirement of more than one surgery. How many times, like we have seen patient and coming back to us, oh, I understood, I'm not satisfied, I understood it was to be like properly done since first time. So we have to explain to them that we have always a way to improve the cosmetic aspect. We have to highlight mainly the importance of the oncological safety first, but then for the cosmetic outcome, we can definitely achieve, we can definitely still do like multiple additional steps in order to help her achieve the better aesthetic outcome that she requires. We should always be very highly educational and explanatory when we explain the risk, when we explain what to expect after mastectomy. Of course, we are having a good aesthetic outcome, but the sensation might be different. We have also to set a realistic expectation level and prepare the patient to that, and monitored all these kind of surgeries during the recovery, and explain to the patient how often she will need to come. Now, of course, as I mentioned before, the limitations are the involvement of the nipple areolar complex, sometimes definitely advanced stages of the cancer, if it's like taking the skin, or sometimes if it is, there are some anatomical factors related to the patient herself. So we have to be aware of the limitation of for this kind of procedures. So individualized evaluation is a key. As previously in the de-escalation from mastectomy to conservative surgery, the same from mastectomy to skin nipple sparing mastectomy, individualized evaluation is a key. So there is no one size fits everyone. We have to consider mainly the oncological safety, have the proper surgical expertise in order to properly explain to the patient, evaluate, discuss in a multidisciplinary approach, have a proper evaluation and proper pre-planning to have achieve a better outcome surgically and psychologically, and have a proper careful follow-up in after the procedure. I'm sorry. Now, another chapter in the de-escalation I would like also to share with you is the vacuum-assisted excision that is getting introduced more and more, again, but not for every kind of lesion. For very small lesions, benign lesions, we have those procedures that are now very, very minimally invasive, image guided, and then it can remove those small benign lesions without having to go ahead with a surgical approach and a scar to the patient. So we don't need any more large surgical incisions, no general anesthesia. This is an outpatient procedure, very fast recovery that can be done in the OPD, in the breast interventional radiology department. So, but we need again to be careful with our indications for benign breast lesions, the high risk lesion very carefully selected, very small, well defined abnormality, and again, very well pre-planned with our breast interventional radiologist based on the location of this lesion. How far is it from the skin, from the nipple, from the chest, the size of the lesion. Most often, like the limit would be like around 13 millimeter, benign or high risk lesion, then we can explain to the patient the feasibility and the indication for the VAE. So again, depending on the pathology results, the imaging characteristics, and the size, mainly the size and the location of this lesion. With our multidisciplinary team discussion and review, we can decide if the patient is eligible for the VAE or not, and then we explain it to the patient and we help her with her decision. It's done under local anesthesia with image guidance, and the vacuum will allow to aspirate the total lesion and we send it again to the pathology with very low complication rates. However, careful planning should be done, as I mentioned and I highlighted again, depending on the type of the lesion and the location of the lesion in the breast. So in our series, we had a good success with complete lesion removal. Again, the size, the choice of the size of the lesion is very crucial, and it will reduce the need for open surgery in those selected patients. The procedure is very short and usually very fast, and the post-operative, post-procedural follow-up is usually very positive. However, we need to be careful. It is not to proceed for malignant lesions, for a very large lesion, and for inadequate lesions from the location in the breast point of view. And of course, respect also the patient choice in some scenarios. The multidisciplinary approach in the decision is very, very, very crucial. So it is safe. We encourage it for those benign lesions that are less than 13 millimeter with a safe location in the breast. Now, having finished with the main chapters concerning the breast, the major de-escalation chapter in breast surgery is in the axilla. And you know very well in every kind of conference that we are approaching, and now we will have in the Best of San Antonio this year, you will hear about even more and more de-escalation until getting to omitting the axillary surgery in few scenarios. So again, when I started my career, the staging of the breast was in the axilla with a total removal of the axillary lymph nodes. So the axillary nodal status was a very important prognostic factor, definitely with tumor size and other biological factors. And when we started the guidelines, it was definitely the main, knowing the status of the lymph nodes is the main deciding factor in every guidelines, in every evaluation of early stage breast cancer. And even if we decide about the adjuvant or neoadjuvant, so evaluating the axilla is very crucial in all the guidelines. And if you see how the era from complete removal of the axillary lymph nodes to sentinel, only removing the sentinel lymph node, have shifted the protocols, have shifted the care since 2000, when the ASOG Z11 trial had shown the value of performing only the sentinel lymph node biopsy instead of complete axillary clearance. So you remember very well the way I do, how we were starting in our career. We were starting with full axillary clearance when we needed to evaluate the nodal status, to now shifting to only sentinel lymph node biopsy, and then now analyzing the necessity to go back to the axilla or not if we have less than 3 lymph node positive. So again, knowing very well our anatomy, the anatomy of the axilla, the drainage from the breast toward the lymph nodes in the axilla, knowing our vascular and our nerve anatomy when we are checking the axilla, makes us know that the axillary lymph node dissection has definitely a very crucial role in the staging. However, the role of complication is also important and valuable, from the lymphedema to the functional issues to daily discomfort, 39%, discomfort 10 to 20%. And even in the studies, if we look at the sentinel lymph node biopsy, the rate of complication is not negligible. So this is why we're performing the axillary staging. And if we look at the complication rate, 70 versus 25%, and then also in the sentinel lymph node biopsy, the rate of complication, it was very crucial to highlight again this timeline in the axillary stage. Sorry? Going from the axillary lymph node complete dissection to the sentinel lymph node biopsy alone, then to de-escalating further with the multiple study that I'm showing in this slide, and then towards probably omission of sentinel lymph node biopsy in certain category of patients, depending on the age and depending on the stages. So this was, in summary, the main chapters that I wanted to share with you regarding the de-escalation in breast surgery, from the breast surgery itself to the axillary surgery itself. So what I would like to share as a conclusion, the main concept is the patient-centered care. So there is no one plan fits for all. So we need a proper multidisciplinary evaluation, proper education of the patients, a very good pre-planning imaging and biological centered plan with our MDT, and then sharing with the patient all those clarification to make sure we are adjusting the proper plan to the proper patients to have a good oncological safety and good aesthetic outcome with both safety respected and conserved. Thank you so much.
Thank you a lot, Professor Rita, for this very concise and very amazing overview about breast surgery in de-escalation era. And الحقيقة أنا يعني شاكر لحضرتك جدا وشاكر تعبك وإصرارك على إنك تقولي السيشن بالرغم من يعني الدور البرد اللي أنا شايفه موجود. فيعني أنا مش عارف أشكر حضرتك إزاي يا دكتور ريتا يعني.
It's my pleasure. It's my pleasure at any time.
ثانكس لوت. انا يعني المفروض ان احنا بنفتح الدسكشن بعد السيشن، بس نظرا لظروف حضرتك احنا مش هنقدر يعني بلاش نفتح. كفايه اللي احنا تعبناكي وسهرناكي معانا النهارده يعني.
I'm happy to. I'm fine, to be honest. I'm happy to. If anyone has like any discussion or question, I'm fine. I'm fine to do that.
ثانكس لوت. ثانكس لوت. لو في حد من حضراتكم حابب يسأل بروفيسور ريتا اي سؤال اتفضل. ادخل.
Thank you, Dr. Rita, for this very nice presentation. I want to ask about the VAE.
Yes.
Vacuum-assisted excision for benign lesions. The multidisciplinary team will consist of a surgeon, medical oncology, from what it is for benign lesion. Also, I want to ask about the needle or instrument that will evacuate this lesion, and if it is done sonographic guided, image guided. I don't know this procedure before. It is not available in our locality here in Aswan.
Yes, so I'm happy that you raised this question. So the VAE is definitely, it is newly applied. So what we usually use for is the vacuum that the breast interventional radiologist is using for the vacuum biopsy. So it can be done under ultrasound guided vacuum. So it is the vacuum applied with ultrasound guidance to the image. once we have pre-localized, and then once we have evaluated properly the location of the lesion. So the way we function in our team is breast surgeon and breast interventional radiologist in our evaluation of the lesions of every case. So when the lesion is benign, the lesion is less than 13 millimeter in the size, and it is in a location that is far from the skin or from the nipple, then under local anesthesia, the breast interventional radiologist, with or without the presence of the breast surgeon, can go under ultrasound guidance using the vacuum machine that she uses for the biopsy, and then aspirate this lesion, and then we will send it again to the pathology. So it is a procedure that is performed the same way as when we are doing the vacuum biopsy, but it is for larger benign lesion, and the patient will not have to have the incision that we do for lumpectomy. It will, believe me, it is something at the beginning, it is difficult to convince a breast surgeon that we can remove that with only a very tiny incision that is the size of the needle. But believe me, it's very beneficial in the long-term outcome. But again, we have to evaluate properly. It depends on the type of the lesion. So benign or high-risk lesion, definitely not the DCIS, not the malignant lesions, and depending on the location of the tumor in the breast.
Which one of the problem of VACAM, we deal only with benign lesion, not with malignant lesion, because
Correct.
because we are taking the lesion bit by bit.
Correct. Correct. This is
And
what.
this can, okay.
Correct. I agree totally with you, Dr. Brahim. We need to highlight very carefully. It is not for malignant. It is not for DCIS. So, and we have to really, really be careful. It's only for very benign lesions and very small, less than 13 millimeter in our team.
There is another system which you call breast region excision system, which are using the radio frequency waves to resect very small micro calcification or micro tumors below 5 to 7 millimeter, and we can remove it with safety margin, and we can localize it after remove it. We put a clip in the site of the tumor, which cannot be done by the vacuum.
Yes, but I'm a little bit skeptical about the radio frequency because for me, I'm still in the concept that everything should go to pathology. So I'm a little bit uncomfortable with radio frequency because we cannot have the tumor, like whatever we are removing, sent to pathology. So
We must
a little bit.
we must send it for histopathology. We cannot
Yeah, but the radio
ignore.
frequency, it will destroy it will not remove, right?
They are working by the interventional radiologist. They are working by radio frequency around the area, not direct to
Oh,
the
I
area
got
of.
it. Oh,
Yes.
okay. I
And we
got it.
put a clip in this site because we need to localize the area which you take in the biopsy if it is positive and need another wide local excision.
Agree.
Okay. If there is any question, another question for Professor Rita? Okay.
So Rita, I asked if the VAE is recommended for cases of small fibroadenoma, which we treat it previously with conservative manner and follow up if a small fibroadenoma within the breast, 8 millimeter, not palpable or undetected sonographically, we follow it. Follow up on conservative management. It is recommended for this line of management?
Now, usually 8 millimeter fibroadenoma, usually it is not wrong to follow it up. Now, again, it is a patient-centered care. If you have a patient, she's not sleeping because she has this little 8 mm fibroadenoma and her life is miserable for some reason because of it, you can consider it. But usually fibroadenoma 8 mm, we usually recommend the follow-up for the patient. We bring her for like 6 months follow-up.
We must tailor the management of every patient alone, not every patient fit for every treatment.
Correct, correct.
Okay. Is there another question for Professor Rita? يعني, all of our attendee is enjoying your presentation, Professor Rita, which is easy and comfortable for everybody.
It's my pleasure. And this is like, because this way it will keep messages in the mind. And then from those messages, we can escalate our research and our look.
Retention of information is very important to be repeated once, one and one, again and again, because there's a lot of changes occurring all over the world by the research work and by all the studies which done all over the world to detect the right changes in treatment, especially in breast cancer. A lot of changes in last 10 to 20 years were
It's a
done.
huge. And our
Yes, yes,
generation, we started with from the axillary complete clearance to
yes,
now.
yes.
So it's every time we're living a huge like change, and it's really amazing.
And may can reach to be de-escalate the surgery of the axilla at all.
Correct, correct. They are this. I think now this year with the San Antonio Best of San Antonio, we'll be hearing a lot of summaries about that.
Yes, but still not the standard of care. The standard of care till now,
Yeah,
sentinel lymph node.
correct. We should be careful. Correct.
Yes, yes. Again, thanks a lot again, Professor Rita, and we hope to be we reach other in another meeting soon. But in good health, and you are
Thank you
to be
so much.
joined
Thank you
with
so
us.
much.
Thanks a lot.
Thank
Thanks a
you.
lot, Professor Rita.
It
Thank
was
you.
a great pleasure. Thank you so much.
Thank you. Thank you, Professor Rita.
Thank you.
See you soon.
Thank you. Thank you so much.
باي باي. شكرا لكل الحضور، وان شاء الله هنزل اللينك بتاع تسجيل السيشن بتاع اليوتيوب على الفيسبوك، علشان لو حد حابب يسمعه او حد ما كانش موجود وحابب يراجعه، اهلا وسهلا بيه. احنا كده عندنا 93 موضوع على الشانل بتاعتنا، تقدروا حضراتكم تراجعوها او تدخلوا عليها في اي وقت. شكرا للجميع على الحضور، شكرا جزيلا. مع السلامه، نشوفكم الاسبوع الجاي ان شاء الله.